It's 12:02. We'd love to go ahead and get started with our works in progress today, and I'm actually really excited to come and hear this work of Daisy and Mary. They're going to be splitting the time here. They've been here at the University of Utah since September. Yeah, September. So have some phenomenal work that they have done in East Africa, in Kenya. And Kate, if you have things that you'd like to introduce them more with, go ahead, but then we'll turn the time over to them.
Yeah, well, thank you everyone for being here. Such an amazing opportunity. We've been so lucky to have such an incredible cohort of students and clinicians and just amazing humans join us from both Kenya and Rwanda. And so it's such a pleasure to get to hear Mary's work. And just a brief introduction. I know everyone saw the flyer, but she is a technical officer and has a Bachelor of Nursing and works with JPIGO in Kenya, as well as very well educated, also another master's from Scotland, and she is certainly an expert in the implementation of obstetric safe surgery. And we are so excited to hear more about her work and her projects. Thank you so much, Mary.
Thank you, Dr. Price, and thank you, Kate, and welcome for this presentation. We are going to present on obstetric safe surgery program in Kenya with my colleague, Dr. Daisy Ruto. So I'll start on the presentation. Thank you so much and welcome.
Look like it. Reconnecting. All right, sorry, we're working on just reconnecting real quick to have the PowerPoint show up. So give us 1 sec with our technical difficulties and we'll get started.
Recording in progress.
It's on my screen.
Great. Sorry for that, and thank you so much. Dr. Daisy Ruto will take it up for the introduction of the obstetric safe surgery program in Kenya.
Hi, good afternoon. Good afternoon, all of you, and thank you for joining this meeting. Yes, thank you for joining us this afternoon. So we do work in a program with Mary in Kenya, where we aim to improve access to quality obstetrics and anesthesia care for our women. And just as a background, Kenya is among the 10 top countries that contributes, globally to maternal mortality. The last official statistics from Kenya which we have used is 2013. We do not have any other one at the moment. But maternal deaths in Kenya are also largely due to workforce-related factors. In 2017, there was an assessment or a confidential inquiry into maternal deaths, and it did show that there were health workforce-related factors that resulted in those deaths. Among those factors, it included delay in starting treatment. You can see about 33%. Inadequate skills was the other big issue, and inadequate monitoring. Now, in Kenya, the main cadre that performs cesarean section are called medical officers. These are the newly qualified post-internship doctors. And because we do not have enough obstetricians out there, so majority of the patients who come to the hospitals for cesarean section will actually undergo a cesarean section by these medical officers. So when these women died, from the assessment, about 54.1 of them, died in the hands of these medical officers. Not that they caused the death, but because they are the primary doctor offering these services. Majority of those deaths that from this confidential inquiry showed that it was associated with cesarean section, and you can see about 70.8% as compared to normal delivery. So we do have a challenge with the cesarean section rates in our country, and WHO provides an optimal CS rate of about 10 to 15%, of course, at population level. Below this rate, they can be increased in terms of harm, both maternal and perinatal. And this is usually largely due to issues around access. And the rates that are quite high are really unlikely to improve any maternal or perinatal outcomes, and sometimes even causing harm. We do see a lot of these very high rates, for example, in the private sector, and for us, some rates below 10%, we see that in part of the public sector. So both extremes need to still be there, but majority really needs to fall within the 10 to 15% WHO rate. But our aim is to avoid both overuse and underuse, meaning that we want to provide a CS before it's too late, and we do not want to have too many cesarean sections too soon. So understanding that context of where we are, all our facilities, and the issues of access that includes the number of CMONC sites available, the terrain and geography, how easy these women can reach to a center where they can get cesarean section is quite important. We need to really understand all those drivers that affect safe, respectful birth. And of course, even as they come for the cesarean section, the enablers, the barriers, both clinical, which include the provider skills, equipment, infrastructure, and even the non-technical or non-clinical skills are quite important. So timely and safe cesarean section can avert 100,000 maternal deaths. This is about 20 to 30% every year, and can also reduce neonatal mortality by 30 to 70%. I think we have seen, the articles from Lancet all show this. And there is also an article that shows African mothers are 50 times more likely to die after cesarean delivery than those in the high income countries. Of course, a lot of challenges with that, including, sepsis after cesarean section, bleeding, so many factors that make these African mothers more likely to die. The risk of maternal death following CS, when assessed, does not differ between the obstetrician gynecologist and the non-obstetrician. And also in our country, we do have a non-physician cadre called reproductive health officers who are also allowed to perform cesarean section. When all these groups are compared, none of them, was of more risk than the other. So we received funding from Johnson & Johnson to implement this project, aiming to support the government of Kenya to reduce maternal and neonatal mortality and morbidity by improving access to safe, quality obstetric, surgical and anesthesia care. And we were a couple of partners within this consortium. JPIGO led the consortium. We had the World Federation of Society of Anesthesiologists, and locally we worked also with the Kenya Society of Anesthesia. Of course, the national level, because of issues of policy, have to be involved and support with the supervision. We implemented this project in 10 sites. We had to start with 5 implementation sites, a total of 4 gynecologists in this county. This is Makueni County. And we had 17 CIMONG sites, in total 10 public and 7 private. This grant was specific to the public sector. And these are some of the interventions that we implemented. Of course, we did have a huge clinical training component that included training for the medical officers, standardizing how they perform cesarean, really improving their skills, but also training them within a group setting. So we used a group-based kind of training to make sure that the entire surgical team within theater also had capacity. They were talking to each other and also communicating well for the success or to improve the outcomes. We also had a leadership training so that these surgical teams then are able to demand from their counties, accountability in terms of funding to support these services within their facilities. They often lack equipment, good infrastructure, and so the leadership training did take them a step ahead in terms of being able to reach out and request for all those things that they do lack. Data is a big challenge. So for this project, we were able to work on that. We developed a register that for use in theater, as well as even a register to track these women out of the facility when they were discharged back home. And then we supported a huge community health intervention where we were tracking these women on day 7 and day 30, and really trying to be as accurate as possible in terms of finding out perioperative mortality rates, surgical site infection rates, and also reviewing, making sure the mother is able to get a referral back to the facility if she had any complication with her cesarean section scar. If the baby was fine, we were able to document that. We developed literacy materials for these women. There's not much out there, but the women need to understand how to care for their wound, nutrition, all those aspects we were able to do to support the women. And then I mentioned the tracking of the women. Most importantly, for this program to remain sustainable within the county, we supported development of an implementation, a costed implementation plan, where we expected this government, this local government, to actually say exactly where they would get resources to continue to support the program. These are some of the areas of focus for us in the clinical training. Big emphasis on teamwork and communication. Previously, we noted that the surgeon doesn't talk with the anesthetist, does not talk to his to their assistant surgeon or whoever is circulating. But this program really makes sure that they do receive the patient as a team, sign in, and eventually even sign out, discuss pain management together before the patient can go back to post-recovery. So it also improved the shared decision-making between the team and the patient or the mother. We held, for this project, we did hold regular briefs and safety hurdles. Apart from standardizing the clinical skills for the surgical team, the anesthetists were also taken through some aspects of standardization. Most of our cesarean sections are conducted through spinal anesthesia. A lot of challenges with us, with that, we've been able to lose mothers because of, hypotension. And so these anesthetists were really supported to make sure that we do not have anesthesia complications and reduce those maternal mortalities. And then also PPH is the main cause of death, even within cesarean section. So training them on PPH was quite a big issue. So I'll turn it over to Mary to continue to share with us the achievements.
Thank you very much, Dr. Daisy. So during our program implementation, there's one thing we realized it has never been used in our setting, and that was the basic tool when it comes to surgical care. And it was the surgical safety checklist where you have to sign in, time out and sign out. And when we went in for the program implementation in January, there was nothing. Then we did our first training in March. And after that, there has been utilization of the surgical safety checklist by the teams. We realized that by the end of it all, some of the cesarean sections could be over, and the doctor who is doing that will ask, what was the name of the nurse who came to pick the baby? What was the name of that anesthetist? So surgical safety checklist and made sure that the teams talk together with the mother, and they can make a shared decision-making. And also this has assisted basically in reduction of errors which occur during the surgical interventions. The other thing about the surgical safety checklist, we included the vaginal cleansing, which was not there, the IP bundles, that was the abdominal preparation, the vaginal cleansing, and the antibiotic pre-op for the mothers. And this has been captured in our setting. So there has been a sustained use of that surgical safety checklist for all the mothers, and it has been embedded in our maternity files for now in Makueni County. In terms of the babies receiving delayed cord clamping and skin-to-skin care, we know that this is very key because most babies die because of hypothermia. And we realized that the surgeons were in a hurry to give out the baby and suture the mother back. But with this, they at least delayed the cord clamping for 1 minute for the stable babies. Then they made sure the baby and the mother were in one room and they were breastfeeding within that 1 hour of surgical intervention. This was not being done, so it's a new thing in Makueni County. And by the end of it all, we were asking ourselves why the surgeons were in a hurry to hand over the baby to go to the maternity unit. On post-discharge tracking of mothers for surgical site infections, in our setting, we usually discharge the mothers on the 3rd day. So within that window period, and most of them, even if you give them a return date of 2 weeks, they never show up because they want to go for 6 weeks. The issues of access, even to the CMOC facilities, it's an issue. And also, we only have 4 gynecologists in the whole county. So that means that the other 6 facilities, public sector, they are manned by the medical officer and the reproductive health clinical officer. And we also only have 1 anesthesiologist in the whole county. So that means there is a gap in terms of the skills and the like. So we have to make sure our mothers don't go back home and die there. So that is why we initiated the post-discharge tracking on day 7 and day 30. And this is for the mother and baby pair, where we even do an audit of the perioperative maternal mortalities and the neonatal deaths in our setting. We realized that we get most mothers on day 7, but the trend declines on day 30. And when we went back, we realized that some numbers don't go through because our terrain is, some areas are hard to reach and there's no network coverage. All the numbers the mothers give, they are not their real numbers. It's the number of the next of kin who either moves to a town setting or not. And most mothers come to the town setting because that is where most facilities are based for CMOC, and they go back to the rural areas after they give birth. Then we have a migratory community, the Maasais, which border Tanzania, and it is usually very hard to get them on phone. Then due to our good quality care, we usually cater for at least 4 counties who refer mothers to Makueni County for care. So that is why post-discharge tracking is very key in our setting so that our mothers don't die at home. So for the surgical site infection, we can see there was basically no data before we initiated the first training, but you can see there was a spike, especially between March and August. When we realized that it was not because the surgical site infections were increasing, but because that after the training, the clinicians were very key. But after that, we realized most of the time they were just indicating, even if a mother came with pain, they were just indicating it is a surgical site infection. So we didn't know whether it was skin, superficial, or deep organ. We went back for the second training, and that is where we laid things out. And we also gave posters so that in all the service delivery point, they can pick out a surgical site infection. And even during the referrals, it can be known where the mother came from. So that is why there was a spike, then a stabilization in terms of the surgical site infection in our setting. Then the issue of the infection prevention bundles also were taken seriously by the teams after doing the audits for the mothers who had the surgical site infection in different sites in the county. So for the postoperative deaths, we know what happened in 2021. You can see the spike. There was COVID, and most of these mothers died in theater because they desaturated so fast. And after that, we have been having 1 or 2 maternal mortalities in our settings, which most of these deaths in our setting is basically due to PPH, and we know CS accounts for 70% of that. And that is why the anesthesia team was brought on board in terms of the PPH management. We realized that they were giving 40 international units before for mothers, but now it has been reduced to 10 international units for oxytocin. So that was another thing which was bringing our mothers even to have hypotension in our setting. So this has been taken care of during the second training, and those continuous mentorship by the teams in urban spoke model has taken care of that, and also cross-monitoring our mothers for perioperative maternal mortalities. We know that we only have 4 gynecologists in our setting, and we have 10 CMOC public sites and 7 public sites. So what happens, because these gynecologists cannot be everywhere. So we had to layer on a technology to catalyze safe quality cesarean section. And the technology we had layered on was called Proximi, where it was secure, and it was installed in 5 CMOC facilities, and it could run with a low bandwidth. And it was like a virtual scrubbing. With a phone or a laptop, you can, if you have a login credentials, you can go in and support the other team in a remote area. Then by the end of it all, they used that for video library, where they used to do cesarean sections, they record, then they go back and later see what happened in that setting, whether it was the good thing. And this has assisted in skill standardization, especially for the medical officers and the reproductive health clinical officers. So for the proximity technology, it has 4 fields. One field shows you the incision site where we have the PTZ camera, which can zoom in. Then the other one shows you the setting of the theater. Then the other one shows you the setting of the anesthesia machine. Then the other one mainly measures on who is doing the operation majorly so that you can support that in any part of the world. So we did the monthly data review meetings using the digital technology. Then after that, we did the referral pathways. We could monitor if it was a bad outcome, where was it coming from, or where were the consultants being called upon by the teams to support majorly. Then there was the issue of quality improvement, where we had to seal in the bottlenecks and in care delivery. Then the virtual and in-person mentorship and the blended learnings. So I'm going to take you through the proximity technology so that we can understand about the virtual scrubbing. Thank you.
When it comes with mandates from Johnson & Johnson to address the issues of obstetric safe surgery. And this is basically ensuring that we are implementing global standards in terms of the cesarean sections that is undertaken on pregnant mothers.
Sometimes there's more than and several complications within their facilities. They require support from the consultant. And what we say is that where she delivers should not determine the outcome of the service or the outcome for her and the baby.
Technology is not a drop and learn adventure. Its deployment requires a thoughtful co-creation and reinforcement with local champions, and this ensures ownership and good uptake from the one go.
Proximity technology has greatly assisted us to mentor our junior doctors, the medical officers, and the clinical officers in reproductive health, who are part of the team that we work so closely with the maternity department to take care of mothers and perform cesarean sections in our hospital.
CS. Sikuwa naona ni kitu mzuri hata. Nilikuwa nasikia watu wanasema sijui utakuwa mlemavu leo kufanyiwa CS. Lakini ile kufika hiyo kwa hiyo room nilifurahi wenye nilipata hapo tu, walikuwa na upendo. Walikuwa tu wanaelezea mtu vile watamfanyia. Ni mazuri. Na nilifurahia hata kuifanyia kwenda kujifungua nao.
About 2 or 3 months ago, we had a mother who had developed massive bleeding after a normal vaginal delivery. So we had to rush the mother into theater. We did open the abdomen and found that the uterus had ruptured on one side. So our consultants were following the process online. They just watched how the uterus was. They did give us instructions on what to do, how to arrest the bleeding, and the entire operation is successful.
Right now we are able to support this medical staff who are performing most of the services. And then we are able to write us and can whenever they anticipate and they end up with complications when they are performing the procedures, then we are able to log in.
The 15th of proximity, we rely on technology, and then Kenya has very forefront, and it has been a 10 days of technology. A good example is the MSI trying to bring in technology in healthcare provision to ensure that we offer quality and efficient healthcare to our mothers who are coming to deliver within our facilities.
It has enhanced develop our skills, especially in the infection prevention manuals of the vaginal cleansing and the skin prep. Hospitali, hiyo ndio ilikuwa challenge. Si kama vile kujua ni serious, kushtuka, sema maybe sitapata. Then ikakuwa tu kwa nilipata udo sikuwa naamini hiyo serious. Lakini nikapata ni kitu vizuri juu nilipata mtoto kama ningengoja niseme sitaenda. Maybe singepata.
Thank you. So from our implementation program in obstetric safe surgery in Makueni County, we have realized that by the end of the day, county ownership and leadership is critical. And that is why we talked of the costed implementation plan in terms of budget allocation for continuity of care for these mothers. Then we have realized that the surgical safety checklists, it improves the quality of care in our mothers, though it has low utilization and awareness, especially for other surgeries, but in cesarean section space, it's being utilized. Then the surgical safety checklist improves teamwork and communication among the surgical team members and improves maternal and newborn outcome. Then the use of obstetric safe surgery curriculum. This is a unique curriculum which was piloted in Makueni County, and it improves the quality of care, especially in skill standardization for incision making in cesarean section. Then by the end of it all, because we have issues of human resource, mentorship is very critical. We know that the 4 gynecologists cannot be in all the 17 facilities. That is why we have to standardize care across. Then the community also has a factor in terms of seeking healthcare, the first delay, the second delay, and the third delay, especially the first delay, because of the myths and misconceptions in seeking healthcare and cesarean section. So that is why we had to use different avenues, that is the community health promoters and the media, so that we can debunk the myths. Then with minimal cost, we can do the post-discharge tracking. It's just a matter of providing a phone and airtime for these healthcare providers. Then virtual mentorship is doable for skills transfer in our setting. So in all that, what are our recommendations and what can we do together so that we can improve quality of care, especially in low and middle income countries? One is to develop a sustainable post-discharge tracking model for healthcare providers and for community also, so that we can have the sustainability and scalability, not only in our county, but the whole country at large. Then the postpartum client monitoring. And this, we realized that most of these mothers, because we have to monitor a mother for 15 minutes for the first 2 hours, it's not doable in our setting. It can be one nurse with 20 mothers, and 3 are going in labor, 2 are going for cesarean section. So early identification of danger signs in our setting might be an issue, and that is why client monitoring becomes very difficult. But those are things we can do with what we have. Then scaling up of obstetric safe surgery in other counties for skill standardization. We have had doctors who come for locum in Makueni County. Then when they come, they are shocked on what we are doing, especially the vaginal cleansing, the preoperative antibiotics, and the abdominal skin prep before operations, and they take it back to their counties, which has been a great learning for us. Then we are advocating for the Ministry of Health for the obstetric safe curriculum, and this has been done through the Department of Reproductive and Maternal Health Services, and we are still working hand in hand with the Ministry of Health. Then we are still disseminating the learnings and the best practices we have done, especially in the conferences, in our settings when we get an opportunity. Then by the end of it all, this is a great avenue for our students here and in our country to come and learn on project implementation, especially in our low middle income settings, so that by the end of the day, all these things, because with innovations, we can make a change. It is doable in our settings. Thank you very much. And I take it back to Dr. Price. Thank you.